It's a pleasure to be here. I usually give these talks to colleagues, medical professionals, and it's really an honor to be giving this talk to caregivers and patients, survivors, because really you're the pilots and we're only here to guide the journey. I want to focus a little bit on systemic therapies. So as a medical oncologist, our role really are the medicines that we give through the IV, by pill, et cetera, with the goal of treating the cancer systemically. Right? So as Dr. Pohar mentioned, this begins all the way even in the muscle invasive setting, and then of course also when the cancer has spread out more and is in metastatic or advanced setting. So I want to start with two patient stories. These are my patients. The names are fiction, but definitely the stories are inspired by real patients. Miss Mary Rose, she's a 60-year-old female. She's been having intermittent abdominal pain, was found to have hydronephrosis, meaning an enlarged kidney because of blockage and urine backing up. And in the ureter, so the tube that connects the kidney down into the bladder, around that they saw an 8-centimeter mass, so a very large mass. It was invading blood vessels in the area. So you can imagine this patient was experiencing a lot of pain, difficulty sleeping, difficulty eating, just not feeling well. When I first met her, she came in on a wheelchair because of how poorly she was feeling. In terms of workup, when they did a cystoscopy, of course, they saw this tumor in the ureter and they couldn't pass the camera beyond the ureter. The biopsy was consistent with urothelial carcinoma. So this is important. When we say, quote, bladder cancer, we have to be mindful about where is the cancer really coming from, because the urothelium are the cells that line all the way from the central part of the kidney down to the tube, down to the bladder, and even further down into the urethra. Right? So the urothelial cancer can arise from any of those parts. Treatment in the advanced setting, for the most part, is very similar, but there are nuances, and it's important to understand this can start really anywhere. So the biopsy was consistent with urothelial carcinoma. They placed a stent so she can have normal renal function. And we did genetic testing to see if this is something she inherited from a family member. And we will go over a little bit more about these terms because these are being mentioned a lot in clinics, genetic testing, what does it mean to sequence my tumor, what does it mean to do germline testing, but this patient did not inherit this cancer from a family member. So her first treatment, because this tumor was so large, even though it had not spread anywhere else, just in that area it was so large that surgery was not. She started treatment with enfortumab vedotin and pembrolizumab, received 8 treatments, and in between had imaging which continued to show shrinkage of tumor, ultimately decided to undergo surgery, and under the microscope, there were no cancer cells left. So even though on scans we could see a tumor, when we actually took it out, there were no cancer cells left. And the patient, after surgery, after much discussion, decided that she did not want to continue any more systemic therapy until it became clear that the cancer is recurred. So this tells us how the modern treatments are really changing what the future looks like for our patients. The other patient story of Mr. Dan Martin, he's a 60-year-old male, high school teacher, initially diagnosed with non-muscle invasive disease, locally treated, and a few years later had recurrence of this tumor, not only in the bladder, but this time had metastatic disease. He initially, so he had sequencing of the tumor done, and the tumor shows an FGFR mutation, and we'll talk more about that. The tumor also expresses HER2. We'll talk about that. So its initial treatment is chemotherapy, followed by immunotherapy. When the cancer progressed, he received enfortumab vedotin. Cancer progressed, he received erdafitinib because he had the FGFR mutation. And when cancer progressed, received trastuzumab deruxtecan because of HER2. So this is just an example to show how many different types of treatments now we have available for our patients. And this does not include many clinical trials that this patient himself and many of our patients are able to enroll on because of the genetics of the tumor that we find. So with this, I just want to kind of lay out, for the longest time, chemotherapy was really the backbone of bladder cancer. Cisplatin or carboplatin, we realized not all patients can receive cisplatin chemotherapy. Bladder cancer is usually diagnosed in later years of life. Fatigue, tiredness is a problem. Kidney function really can be affected with cisplatin chemotherapy. Hearing can be affected. Numbness, tingling, which in at least a quarter of patients becomes permanent and lifelong. So there was always a need for more treatments, right? So really this, you can see the journey started in the last 10 years or so, where immunotherapy was first approved for patients who had cancer that progressed on chemotherapy. And then immunotherapy was brought into earlier lines of treatment, meaning to say, let's combine this as our first line of treatment for patients with bladder cancer. Let's combine it with chemotherapy. You also see another agent here called enfortumab vedotin, same thing, initially approved for patients who had progressed on chemo, and we saw how wonderfully it works, and bringing it into earlier lines of therapy, saying, this is what we should start our patients with when they're first diagnosed. And then more recently now, seeing how effective these treatments are, bringing into curative setting, meaning folks who have muscle invasive bladder cancer, this cancer has not metastasized, and saying, can we give this treatment front and then take our patients to surgery so we have higher likelihood of cure? So just talking a little bit about genetics, mutations. I don't want this to become too complicated, just keeping things very simple, right? DNA in the cell nucleus is what informs the cells what kind of proteins to make. And proteins form everything, the color of our eyes, the color of our hair. When the DNA has changes, the protein that it makes is no longer normal, and that's what allows cancer cells to grow. These mutations can happen either in cells or DNA that we got from mom or dad, or it can develop in the cancer itself as the tumor is developing. Okay? So on the left side of the screen, when we say germline mutations, we are talking about genes that patients received from mom or dad. This is something that can be passed on to the offsprings later on. This is typically tested in the blood or in the saliva. And this can increase risk of other types of cancers. So when I ask patients, do you have other family members with cancer? Many times they may say nobody with bladder cancer, but it's important to also know other cancers. Right? So upper tract, when I said, how cancer can also arise in the tube connecting the kidney to the bladder, a good portion of those patients, up to 10 to 20% of those, are in fact inherited urothelial carcinoma. So really, these patients should be having germline testing if they are diagnosed with an upper tract urothelial carcinoma. Okay? And Lynch syndrome is very common. So Lynch syndrome increases risk for colon cancer, female cancers of the genitourinary system. So genetic testing, germline, that's what we're referring to. And if this comes back positive, patients will be referred to genetic counselors because this will affect other members of the family. Somatic testing, on the other hand, we are looking for genes that the cancer develops over time. This cannot be passed on to other family members, but this tells us as clinicians what treatments this cancer is likely to respond to. Okay? And this can, again, be done on the blood and many times on the biopsy from the tissue itself. And then lastly, circulating tumor DNA. This is a newer technology being used more and more in clinics. So you will hear more about this from your providers. As cancer cells grow, they release DNA into the bloodstream. We can take that DNA to not only learn about the mutations, but also to measure it over time. And if the cancer is responding, what we want to see is that the number of the DNA in the bloodstream is getting lower and lower. And this can help us guide, along with imaging, in a much more sensitive way, whether we are headed in the right direction. So talking a little bit about the treatments that I've mentioned so far. So first of all, immunotherapy, Keytruda. You see the ads for this on TV. I don't know if I'm allowed to use commercial names, so generic is pembrolizumab, and the other one is nivolumab that we use frequently. So, in the normal situation, our body's immune system should be able to fight cancer. Okay? Cancer cells over time develop ways of bypassing the immune system. So with immunotherapy, we are really taking the brakes off of the immune system and retraining the immune system so it can do its normal job, which is to fight cancer cells. Right? So the immune system not only naturally has these stop signs built in, but cancer cells learn a way to really upregulate these stop signs so the cancer cell is not able to be under the influence of the immune system. These immunotherapies take the stop sign away, and the immune system is able to eradicate the cancer cells. So immunotherapy goes hand in hand with other treatments in bladder cancer, such as chemotherapy, especially in the muscle-invasive bladder cancer setting. So, someone may ask, well, if the cancer is just in my bladder, we should just take the bladder out. Right? The problem is, if you think about dandelions, and this is an analogy that one of my mentors used many years ago when I was training, is if you pluck a dandelion off the lawn, you still have to worry about the seedlings that are going to become a problem long term. Right? So even though the surgery or chemoradiation to the bladder can take care of that dandelion, we still have to give systemic therapy to take care of the seedlings, which oftentimes will become metastatic disease in the future. Right? So for that reason, the standard of care for the longest time has been to give few cycles of chemotherapy before surgery, followed by surgery, and then, depending on how much cancer is left at the time of surgery, to finish up with 1 year of immunotherapy with nivolumab. However, what we are now also learning is that if you've taken the cancer out completely, the immune system really does not have the opportunity to learn what does the cancer really look like. So now when it's going out and looking for these sneaky cancer cells, it's kind of like wearing an eye mask and is just not able to really fully figure out. But if the cancer is right there and we give immunotherapy ahead of time, it's like sending the immune cells to grade school, and they can really get in there, learn what these cancer cells look like, and then do their job even better. So for that reason, neoadjuvant immunotherapy, meaning giving immunotherapy in addition to chemo before surgery, is the new standard of care. And this comes from a clinical trial where patients received gemcitabine and cisplatin chemotherapy plus immunotherapy called durvalumab, followed by surgery, followed by finishing up 1 year of durvalumab immunotherapy. These patients were compared to those who received just chemotherapy and had surgery. And what we found is for patients who received only chemotherapy, the chance of having cancer recurrence was 4 out of 10. And if they received immunotherapy in addition to chemo before surgery, the chance of cancer recurrence was 3 out of 10. Okay? So this may not sound like big differences, but if you consider the number of patients who are treated, these numbers really do pan out. However, what we are also realizing is that not all patients really need treatment after their surgeries. So the circulating tumor DNA that I mentioned, what we're learning is that can help us understand if there's really cancer cells left over and do you need more treatment after surgery or not. So on the top you can see if someone's circulating tumor DNA is negative after surgery, the likelihood of having cancer come back is 3 out of 10. And really, receiving more immunotherapy doesn't help a whole lot. On the bottom, if the circulating tumor DNA is positive after surgery, the likelihood of cancer coming back is 9 out of 10. And giving immunotherapy is really helping these patients to prevent 1 recurrence. Okay? So more work needing to be done here. So you will see that at some centers there are clinical trials now open, and I don't want to go into this too much. I know there's a separate session for trials, which are really looking into incorporating circulating tumor DNA after surgery, and those who are negative, maybe we don't need to do anything more. And if it's positive, maybe we should be doing even more than just giving nivolumab. Perhaps they need double immunotherapy to really make those chances of recurrence look more favorable. Okay? So I would say if a patient is diagnosed with muscle-invasive bladder cancer tomorrow, their treatment will look like either getting chemotherapy plus immunotherapy before surgery, followed by surgery, followed by finishing 1 year of immunotherapy, or enrollment in a clinical trial, like I mentioned, where they get chemotherapy, surgery, and then decide if more immunotherapy is needed based on their circulating tumor DNA status. Okay. So now moving a little bit to advanced disease, meaning metastatic disease, or patients who are not able to undergo surgery. In the setting of advanced urothelial cancer, as I previously mentioned, platinum-based chemotherapy has been the standard of care for a very long time. But not all patients are, number one, able to receive those treatments. And even those who do, there is room for improvement. Okay? So much like how in the muscle-invasive setting, we are combining immunotherapy with chemotherapy, same thing. For metastatic patients, a clinical trial was done where patients who received chemotherapy plus immunotherapy or chemotherapy alone, what were their outcomes? And definitely adding immunotherapy was much better. So you can see here on the graphs, the green, kind of this teal color are folks who received immunotherapy. The dark teal are folks who had a complete response, meaning on scans, the cancer had gone away completely. So at least in 20% of patients, by adding immunotherapy, the cancer went away completely on scans. And in total, close to 60% of patients had shrinkage in their tumor, versus if we don't add immunotherapy, only about 40% of patients have shrinkage in their tumor. Okay, so really now the standard of care is to do chemo plus immunotherapy. Or the other alternative is the medicine that my patient received, Miss Mary Rose, which is a medicine called enfortumab vedotin, or brand name Padcev that you may have heard. So Padcev is a monoclonal antibody. So our bodies make antibodies, and they make a whole rainbow of antibodies. Monoclonal antibodies is to say, okay, we're going to make only one type of antibody, modify it such that the cancer cells can take it in, and then release chemo molecules into the cancer cell. Okay? So this antibody attaches to a flag on cancer cells called Nectin-4. The antibody is taken in, and then it releases chemo in the cancer and prevents it from dividing further. So that's how Padcev works. And we combine it with pembrolizumab in the metastatic setting. The main side effects from this medicine, and I know there is a session later about patient experience through treatments, but the main issues are rash, diarrhea, neuropathy, numbness and tingling in hands and feet. If patients have diabetes, that really needs to be well managed because it can increase glucose levels. And the trial that allowed for this treatment to be approved was looking at patients getting Padcev plus pembrolizumab versus chemotherapy. Could be cisplatin, carboplatin. And it nearly doubled the life of our patients living with cancer when they receive Padcev plus pembrolizumab. 67% of patients experienced a response, meaning the tumor shrank, compared to 44%. And the side effects were also better tolerated. And in the experience of my patient, when I first met her, as I mentioned, her performance status was, she was not feeling well. By second or third treatment, appetite was improved, out of the wheelchair, walking, and now when you meet her, she would say that I'm back to my normal self. I feel like myself again. Okay. So options for first-line treatment now are either Padcev plus pembrolizumab or chemotherapy plus nivolumab. And in many patients, like mine, who previously would not have been considered for surgery because these treatments work so well, even in some very select advanced patients, we are starting to think about, should we be considering surgery in these patients if we have no evidence of cancer anywhere else? Okay, but more research work to be done in that area. And then lastly, just to wrap up here in the next few minutes, if the cancer progresses on the frontline treatment, so either they start with Padcev pembro or they start with chemo-nivo, what to do after? That's really where the genetics of the cancer comes in place. If the cancer has an FGFR3 mutation, patients can receive a pill called erdafitinib. If they have a HER2 expression, then patients can receive a medicine called trastuzumab deruxtecan. Otherwise, more chemotherapy, but really enrollment in clinical trials is what should be considered. So just to quickly mention erdafitinib, FGFR is another flag that's expressed on top of cancer cells. It's expressed on normal cells also. When it is mutated, the cancer cells grow infinitely without any regulation. And the medicine, erdafitinib, binds to this receptor, to this flag, and shuts down the cancer production machinery. Main side effects from this, electrolyte disturbance, phosphate levels, so these patients will need to be on a low-phos diet. It can cause nail changes, so we ask patients not to get artificial nails when they're on this treatment. Diarrhea, mouth sores, rash, especially on the palms and the soles. These are the main issues. And then trastuzumab deruxtecan, this is an intravenous. This is, again, a monoclonal antibody, which binds to a flag on cancer cells called HER2. Your doctor will tell you, okay, you have HER2 3+ expression. So there is like a whole, you can say, spectrum of how strongly this flag is expressed. It can go from none at all to 1+, 2+, 3+. 3+ meaning the strongest, and if it is really strongly expressed, then this medicine we know works. More than 50% of patients will experience shrinkage in the cancer cells. Common side effects are nausea, diarrhea. We have to keep an eye on blood counts, and in rare situations can affect the heart, and we have to do serial monitoring of the heart function. So in summary, current modern treatments really have changed the prospect for bladder cancer in our patients. And genetics are becoming more and more important in understanding how to treat these cancers. New technologies like circulating tumor DNA are really helping our patients and us to better select what treatments, do we need surgery, how aggressive do we need to be. And really clinical trials should be considered because a lot of these mutations that I mentioned are also looking at new and newer drugs on how to target bladder cancer. And that's a wrap for me.
Thank you both for such an educational presentation. We will now open the floor for questions from the audience. Before we get started with that, I just have a few announcements. If you'd like to ask a question, raise your hand and we'll have my colleagues come to you with a mic. We see one over here, Kira, and then there's Patrick. I also want to point out that our experts here, they're able to address questions, but they're not necessarily here to give individual medical advice, so please keep that in mind as you ask your questions. With that, I think we're ready with the first question.
I'm 5 years NED, woohoo, and curious about, it feels like this is light years ahead of 5 years ago. 2020. Is that true? I would love to hear more about the time frame of these advancements.
Yeah, so if I go back to my original slide, I would say all of this development really has happened in the last 10 years, but immune checkpoint inhibitors were studied back in the 70s. It's only taken this long to bring these things to the market and really prove that they help our patients with bladder cancer. The other hat I wear is treating patients with melanoma, and that's really where immunotherapy was first launched in terms of being very effective and has slowly made its way. So, at our center, we do a lot of phase 1 clinical trials. So these are early phase trials where, new treatments are being moved from the lab into patients to really assess safety and early signals of efficacy, meaning do we have signal that it works? And I really encourage patients to enroll on those trials for this reason, because it takes so long for treatments to ever hit the market when we know these treatments can be effective.
Okay, Carlos?
Yes, I have a question for Dr. Pohar. I'm a non-muscle invasive bladder cancer survivor. I'm 8 years NED. I'm thankful for that. But I realized I could always get a reoccurrence because bladder cancer does have a tendency to recur. A question I have for you is, you mentioned partial bladder removal. I haven't, I guess I thought Okay, test. Okay. I thought it was either the bladder remained intact or it was removed completely. I haven't heard about partial bladder removal, and I was wondering how common that is.
Yeah, certainly. I hope my mic is on. It's certainly not commonly performed because it's mostly based on the size of the tumor, location of the tumor, and what capacity of the bladder would be left behind if you were to eradicate the cancerous growth with a wide margin. Then there's a certain component of bladder that's left behind, and how functional would that be? Would the individual have to urinate every hour, or would they actually be able to hold it for 2 hours? But it is a well-endorsed treatment option for the invasive forms of bladder cancer. So it's not done commonly because most of the time, unfortunately, the cancer isn't technically the most appropriate to do the operation, but it's something to always keep in mind.
I'm sorry, it sounds like we're having some technical issues with the sound, so we'll try to get that working. Sounds like maybe we need to move the mic a little bit. Okay, we have a question on that.
Yes, back to the partial cystectomy. What exactly is removed in a partial cystectomy versus a total cystectomy?
I'm sorry, I can't see. Where's the question
Right over
coming
there.
from?
Sorry.
Okay,
Oh.
super, great. Thanks for the question. The principles of treatment should not be any different for muscle-invasive bladder cancer, whether you're going to do a radical cystectomy or a partial cystectomy. So the need for chemotherapy, immune therapy, that's all very relevant. So what is actually removed is the part of the bladder that's diseased by the cancerous growth. It's where the cancer is located. That's the portion of the bladder that would be surgically removed. And then what remains, that part of the bladder is sewn back together.
So you would still void normally?
Yeah, you would still be able to void normally. Your bladder would definitely be of reduced capacity, but hopefully not to a degree where it would bother your quality of life to such a degree that you would be miserable.
So what about, so you wouldn't have it wouldn't be as much as a radical cystectomy is what you're saying?
If you could say that again,
The
please.
lymph nodes and all the other things that are removed.
Yeah, it is a good option for treatment in select individuals.
Okay, thank you, doctor.
How you doing? My name's Jim, and I was in June of 24. They went in my bladder to look at removing a couple urolifts. So they scheduled a surgery in February, 6 months later, and they found 2 tumors. They said they wasn't in there in June, and they're high grade, and they removed them. So I went on chemo and Keytruda, and I'm still on Keytruda. So they, first PET scan showed it jumped to a bone in my back. Second PET scan said there's nothing in my body. Still could be in my bladder. So I'm scheduled for neosurgery. Is there anything that I don't have to do that? You know what I mean? I insisted on them doing some biopsies. They did 5 biopsies. One of them showed fragments of still high-grade cells. So that's where I'm at. And that's why I'm here. I already talked to a gentleman over there that's already had neobladder. So I'm looking for information. What do you got?
Did you have a specific question? Thanks for sharing all of that.
I guess the question would be, I seen the bladder saving information. Is there anything that can help me with that? Or should I get the neosurgery? I know I'm not your patient, so.
Yeah, I think it's an important point, and I think it's important that, and I'm sure you're discussing with your care team what the options could be, and would bladder sparing also be a possibility? So I think it's an important topic to always have that discussion with your care providers.
So if I may add, I have a similar patient, so I can't tell you exactly what to do in your situation, but I have a similar patient who maybe had metastatic lymph nodes, right? The PET scan showing maybe some borderline lymph nodes. We treated him with Padcev and pembrolizumab, and if those lymph nodes were metastatic, they went away completely. If they were related to the nephrostomy tube that he had in, infection, et cetera, well, they were not cancer to begin with. So we really had the discussion with him about having surgery or having bladder preservation. And both options were offered to either way do something curatively for the bladder.
As a follow-up to that, I think, oftentimes patients, they're confronted with making these decisions, but it has to be done so quickly. And so what tips would you have that would help individuals in that situation to do what they need to do to be able to feel informed or more at ease with having these conversations and coming to a decision? Are there any tips that you can share?
I would say I have the easy answer. Until they can make a decision, I continue systemic therapy. And I defer the rest of the discussion to patients and their surgeons. But really, I think that can help patients feel a little bit at ease, knowing that they're not, that they're doing something while they are making that decision. And you're right, it can take some time, especially now, not just from patients, but also from researchers and clinicians. There's a lot of interest in bladder preservation. Let me switch mics with you. There's a lot of interest in bladder preservation, not just with chemoradiation, but also recognizing that our systemic therapies are so effective. Should we be doing less? But until we have those answers, I would say the textbook answer from most physicians would be we should be doing something curatively, whether that means chemoradiation or surgery.
Yeah, I would say, it's obviously that's a stressful time in one's life, when you're contemplating decisions and there's some sense of urgency to make a decision. I think Beacon is a wonderful organization to seek out resources, a community, to talk to others. I think that would be an important way to try to help with a decision. Getting other opinions, it's highly advocated regardless of the setting you're in. I think seeking out advice from another provider and getting another opinion, I think all of that together could hopefully drive confidence in being ready and thoughtful to make a decision.
Excellent, thank you. We're ready for the next question on this end.
Here's a question. No one talked on it. So if your cancer is in your ureter, is there a way to just take out that piece and somehow either combine the ureter or get some other, I don't know, or, parts like you do and make a new ureter?
Yeah, absolutely, that can be done.
Good.
So partial removal of the ureter is certainly technically possible. The lower the problem is in the ureter to the bladder, the easier it is to solve the problem by saving the remainder of the ureter and kidney. The higher up it is in the ureter, the more creative and possibly the less likely that is possible, but certainly it's a possibility.
Hi, good morning, everyone. My name is Jordan Hopchick, and I was diagnosed next month with intermediate bladder cancer. And histologically, it showed 95% low-grade and 5% high-grade feature. And it was recommended as a precautionary measure to do intravesical gemcitabine. So I did induction, and then I'm actually in my 10th month of maintenance treatment. And I'm sort of in a clinical conundrum because what I've read and what I've heard from my urologist and also other experts is weighing the risk and benefit of going more than 1 year with treatment. I actually just had, it was my request to have a blue light cystoscopy, and it was negative. My urine cytology and FISH tests have all been negative. So I'm trying to figure out, I'm actually a nurse practitioner and an academic junkie, so I'm always trying to figure out what should I do? I don't seem to really have a strong consensus from experts. There seems to be, the jury seems to still be out whether or not to do more than 1 year. I actually wrote to Dr. O'Donnell from the University of Iowa, who seems to have done a lot of breakthrough in treatment. So I just wanted to find out what your thoughts were on that specific part of bladder cancer treatment.
Well, I enjoy your question and the fact that you're really having deep dialogue with your providers and talking about it. I can see the conundrum because I feel the same way. The strength of the evidence of giving adjuvant chemotherapy for maintenance for intermediate risk, that's not well defined in general. Certainly the field generally espouses to 1 year of treatment, that if we're going to do it, 1 year seems to be our knowledge of, we have some knowledge that that's likely the potentially efficacy, and beyond that it's unknown. So I also live in your conundrum. Don't really know if there's benefit to giving it any longer because we don't have the knowledge. And so that's kind of, I think, where the field is today. We just don't know whether additional therapy would provide benefit.
So what would you recommend to your mother versus your mother-in-law?
Well, I have a very large population of patients with intermediate risk, and I espouse to 1 year of therapy, and then we stop after 1 year of maintenance.
You would recommend 1 year?
1 year, both to, and as well to my mother and my mother-in-law.
Hello, I have a question regarding ctDNA and the research that's being done on it. Do you have any information regarding when immunotherapy, if there is a delay in its effectiveness or the body's ability to learn from it? For example, ctDNA in my instance increased 11 months into immunotherapy, and then all of a sudden it started to drop. Does that mean it just takes the body that long in immunotherapy to learn, or is there some other data that I'm missing here?
That's really interesting. Thanks for sharing that. What we really know about ctDNA on immunotherapy is that baseline and at 6 to 8 weeks is important, because if we really want to see that ctDNA going down by the 3-month mark. Serial draws are important, just like you suggested, but in general, in my experience, if patients are responding, their ctDNA is going down. What you're suggesting, I would have to dig more deeper into the literature just to see if that's really been shown. The other important thing we have to recognize, ctDNA is not perfect. It's still a test that is being developed. So before the most common platform that's being used, they were doing whole exome, meaning parts of the DNA that make protein. But there are also other parts of the DNA that don't make protein. That would be called whole genome. So now their newer platform does whole genome. And many times, even though the cancer is there, the ctDNA cannot be detected for a few different reasons. Either the cancer is just not shedding enough DNA. For example, if the cancer cells are in the brain, they're not going to shed DNA in the bloodstream most times. Bone doesn't shed as well. And then, of course, we have the technical errors of the lab technology, whether it's good enough or not. So this is still a test under development and really should be utilized best under clinical trials or taken with a grain of salt.
Hi, my name's Jim. I'm fascinated by the ctDNA, and this is kind of a follow-up, although we've thought about this independently. So is ctDNA almost strictly a systemic marker? Is there any way to go from ctDNA to origin of the tumor?
Good question. We generally think of it as a systemic marker. There is thought about starting to detect it in the urine. So if folks, for example, only have muscle-invasive disease or residual bladder cancer, but nothing systemically, then the blood might be negative, and perhaps there are other ways of detecting it in the urine. Again, something under research, not currently in the guidelines.
Yeah, I'd have to say, it's kind of interesting that recent studies are starting to demonstrate that in non-muscle invasive bladder cancer, where you'd think the likelihood of having microscopic metastatic disease is probably unlikely in many of those settings, that you can detect ctDNA in the blood of NMIBC patients as well. So kind of an interesting phenomenon.
There's a question here in the front. And I do want to mention that we have a webinar coming up at the beginning of next month that's focused on ctDNA. So if you want to learn more, we will have a dedicated time for that. Yes.
This is a question in regarding to the non-invasive muscle cancer diagnosis and the follow-up, and how far out should follow-up go? Should it go for the rest of the life? He is a 13-year survivor, having just the initial chemo into the bladder after the second term, and then numerous BCGs until he couldn't tolerate it anymore. Went through the follow-up of every 3 months, every 6 months, and is now on annual, and the frequency of scans. I'd like to know where we are with that.
Yeah, that's such a good point you bring up. So we don't have strong knowledge of there's a certain degree of follow-up that's necessary or not necessary. It's based on mostly expert opinion, and we follow guidelines to guide us about how long the follow-up should be done. The guidelines can vary around the world to some degree in terms of what the follow-up is that's recommended, and not surprising in some ways because it's based on expert opinion and the level of knowledge is not that strong. Certainly in the low-risk non-muscle invasive bladder cancer setting, there's uniformity around the world that after 5 years of follow-up, there's no reason to continue to follow up from a medical perspective. In the intermediate risk and high-risk categories, there really are no definitive statements in most guidelines, and certainly the ones we look at in the United States, what organizations we look at, there is really no stop date. So unfortunately, that's kind of where we are. It's expert opinion derived, and many do end up having lifelong follow-up.
Is that, when you said high risk, is that high grade, or is that another definition of that? So like the 5-year mark, would that also include high grade cancer? Non-muscle invasive high grade?
Yeah, sorry if I misspoke. So for the low-risk non-muscle invasive bladder cancer category, which is a low-grade non-invasive tumor, a single tumor, small tumor, 5 years of follow-up is sufficient. But for the other two categories, intermediate risk and high risk, that is not sufficient. Much longer term and lifelong follow-up is what the guidelines are suggesting as of today. Did that clarify the comment? So, do you want me to do better?
So then is high grade considered that intermediate or high risk, whereas low grade is in the low risk?
Yeah, so the intermediate risk NMIBC category is mostly low-grade non-invasive tumors that are larger. There's more than one, or they're recurrent. But there is one small exception in the American guideline, a high-grade non-invasive tumor that's small, newly diagnosed, is intermediate risk as well. But the vast majority of high-grade tumors are in the high-risk category. There's one small exception.
Thank you.
That was a great question, Angie. There's a question there and then one in the back. Go ahead, Jim.
Yes. Thank you so much for what you do, and thank you for being here. That's just awesome. We are from the state of Michigan, and my concern is clinical trials, getting people involved in clinical trials. Some people have this negative connotation about clinical trials that, oh, well, wait a minute, I'm not going to do that until it's like the end of life, you know. So what are you finding in how you're getting people to enroll or participate in a clinical trial? And more importantly, is there a way that you haven't seen here, which is probably not, that we can help you to get people enrolled or involved in clinical trials?
That's excellent. Thank you for that question. I think patients and caregivers, speaking to patients and caregivers helps a lot to build that trust. I was happy to see the list of trials on Beacon's website, so reliable organizations like this, if they are talking about trials, that helps. And you make a good point. I don't think trials should be reserved till the end of line, because trials do expect patients, for good reason, to be in good health. Because we are, as much as we're studying efficacy, meaning benefit, we are also studying side effects. And we want to make sure that our patients are able to, their bodies are able to handle those side effects if they happen. We in general, trials will want what's called ECOG of 0 to 1, meaning patients are either having no symptoms from their cancer, that's hard to find, right? Or having side effects enough that they're still able to go along with their life, are able to walk and exercise and those sorts of things. So if this is the 8th or 10th line of treatment, that may be very difficult. Many trials also have expectations on, could have only received 2-3 prior lines, after which the trial is no longer eligible. So talking to, even if somebody starts their treatment, let's say in a community setting, because that's what's close to home, I really think that, at least if the cancer is progressing on the initial treatment, getting a second opinion at an academic center would be important to ask what trials are available.
Very good. Anything to add?
It's hard to overcome the stigma of clinical trials sometimes, how an individual might view that. I think it's up to us as a community together to emphasize the importance of clinical trials. It's about getting better. It's about trying to be better and improve health and in many parameters. So I think it takes all of us. It takes a voice to emphasize clinical trials are important. They're here to improve the care for everybody in the population.
Thank you for that question, and it's a reason why we have a dedicated session to that conversation this afternoon, so get ready to ask many more questions around that. We'll take our last question, and then we'll say a few announcements before we break for lunch.
Hi, my name is Ron, and I'm dealing with bladder cancer and actually TUC. I'm one of the few people that also had that since 2011. But back in 2000, and I've had BCG, and then I was on Keytruda and back on Keytruda. Back in 2023, my cytology turned out quite bad, and I was told I did not have manifested disease. It sounds better but I had carcinoma cells in kidney and in my bladder and back in my urethra. They put me on Keytruda. I was Keytruda for 2 years. It works, and I was CR, complete remission, for 2 years. And then they said, well, you got to come off of it because there's a protocol, you know, and I guess maybe you folks know more about that than other. I came off it, the cancer came back, and I'm back on it. But I don't know if it's going to work this second time around. So I'm nervous, extremely nervous. I have a CAT scan the end of the month. I guess my recommendation to you folks is if you have folks on Keytruda, don't take them off, ever. I had a friend, and she's active in Beacon, who was on it for 4.5 years, steady. And she was in a situation where her insurance was very good. She finally had to come off it after 4.5 years. She got the colitis, and so she had to stop. But that was 3 years ago. So she's been cancer-free for 3 years. So Keytruda represses, but if you come off it, it could come back. Anyway, I don't know where we stand with this. Do you folks leave your patients on these immunos like that for any length of time? Their immune systems become habituated or get used to this, repress the cancer, and maybe it won't ever come back. What's your opinion of that, or what is your experience with that?
So I'll answer that question 2 ways. First of all, maybe we should talk about pembrolizumab in non-muscle invasive setting. It works, and I'll also love to hear Dr. Pohar's opinions. It works, but it doesn't work for the majority of patients. And the cancer, complete response is in a small fraction of patients. I would say maybe 20 to 40%. The duration of response, meaning how long does that response really last, is not really forever. So, pembrolizumab or any immunotherapy is really depending on, okay, how much partying is going on in the cancer, okay? Meaning how many mutations are there, how much weirdness is there. The more of that, the better pembrolizumab works. And that's a whole spectrum. So non-muscle invasive may not have a lot of that versus, for example, metastatic disease and advanced disease. Okay, so that's number one. Number two, how long to keep these treatments on? Okay, some of this is like an arbitrary number that, when clinical trials are being designed, are said, okay, this sounds like good enough where we feel that this is not too long and not too short. So somewhere between 1 to 2 years is what's suggested. Some folks say, do we really need a whole year? Do we need to do less? So now there is interest in actually dialing back therapy, okay, rather than doing it forever. The other interesting thing is that even though pembrolizumab, for example, is given once every 3 weeks or every 6 weeks, depending on the dose, Nivo given every 4 weeks, depending on the dose, the medicines last in the system much longer. So we know from, you can say, tissue data, blood data, because it is changing how the immune system inherently works, these medicines have effects even six months out, okay? Even after we stopped treatment, patients can develop side effects from their immunotherapy. So if someone had immunotherapy 6 months ago, or let's say, okay, that might be a gray area, 3 months ago they had immunotherapy, and now they're developing cancer, as a cancer doctor, I would say this cancer is resistant to immunotherapy because the immunotherapy is still affecting your immune system and the cancer is progressing despite that. That's very different than someone who had immunotherapy 2 years ago and now their cancer is coming back and we can say, yeah, maybe there is benefit in retrying immunotherapy. So a lot of nuance there.
Yeah, I don't have much more to add, but there's variations in how long immune therapy may be given, and it has to do with, what is the stage of the disease or the state of disease, because our knowledge about the duration of immune therapy in different states of the disease and its benefit has only been studied for, certain periods of time. So I think that's where some of the conversation about the differences in immune therapy amongst different individuals. I think these are factors that impact that.